Hi friends, welcome to Pain Policy Practice. Whether you're living with chronic pain, caring for someone who is, or if you're a healthcare provider, medical student, resident, or fellow, or healthcare administrator, this is where medicine, policy, and real-world practice come together to bring clarity to complex chronic pain care. Today I'll be speaking about the third topic under living with chronic pain, and that is navigating the healthcare system as a pain patient. Living with chronic pain is not only about managing symptoms. It is about understanding referrals, insurance requirements, specialist roles, and regulatory realities. The system can feel very overwhelming, but when you understand how it works, you gain clarity, you reduce frustration, and you become more effective advocate for your own care. Today we'll break that process down clearly, practically, and professionally. If you live with chronic pain, or if you treat patients with chronic pain, you already know this. Navigating the healthcare system can be just as complex as managing the condition itself. Chronic pain care does not occur in isolation. It occurs within regulatory oversight. It occurs within insurance constraints, workforce limitations, subspecialty bottlenecks. So today we're going to talk about how the system actually works, including the role of pain management specialists, and why understanding that structure improves outcomes on both sides of the exam room. Chronic pain is a subspecialty problem. Chronic pain is not simply ongoing acute pain. It is often neurologically mediated, functionally limiting, influenced by central sensitization, intertwined with mood, sleep, and stress. It requires extensive use of interventional and non-interventional treatments. It may need use of extensive chronic opioid therapy or other medication management. So because of this complexity, pain management became its own subspecialty. Pain management specialists complete a primary residency in either anesthesiology, physical medicine and rehabilitation, neurology, or psychiatry. And this is followed by a dedicated interventional pain management fellowship. Pain management is multidisciplinary, procedural, and regulated. So what is the role of primary care physician in chronic pain? Primary care physicians are often the first contact. They manage chronic disease along with chronic pain, mental health, preventive care, and also early stage chronic pain. But when pain becomes persistent or complex, or when patients become functionally disabling and medication oversensitive or resistant, referral may then occur to pain management. Referral from primary care is not abandonment, it's purely escalation of expertise. However, unfortunately, friends, there exists a referral bottleneck. There is a national shortage of fellowship-trained pain management specialists. And so this creates long wait times, strict referral criteria, insurance sequencing, extensive documentation requirements. While PCPs often must continue to attempt conservative therapy or document even failed medications, order imaging, attempt physical therapy before insurance approves specialty referral. Why pain specialists may seem cautious is because pain medicine is highly scrutinized and is one of the most regulated fields of medicine. There is a very strict regulatory oversight. Pain specialists will often have to consider state prescribing laws, Drug Enforcement Administration or DEA, which is the federal oversight, Federal guidelines such as periodically published CDC guidelines on chronic pain management, risk mitigation, and also have to consider Centers for Medicare and Medicaid or CMS local coverage determinations or LCDs regarding documentation standards and urine drug testing, as well as risk stratification tools. Caution reflects regulation and not disbelief. Pain specialists may focus on interventional approaches such as epidural injections, nerve blocks, radiofrequency ablation techniques, or neuromodulation techniques, and so forth. They will also need to focus on multimodal, including emphasis on behavioral therapies, physical therapies, lifestyle modifications, and chronic pharmacological therapy, namely chronic opioid therapy, NSAIDs, anticonvulsants, and so forth. The goal here is improved function with some acceptable risk. There is an inherent PCP pain specialist collaboration. While primary care providers manage continuity of care, including addressing comorbidities, they also monitor chronic disease, they provide stability. Pain specialists, on the other hand, perform procedures, adjust complex medication regimens, manage risk protocols. So patients should always ask, who is managing which part of my care? Effective chronic pain care requires coordination. So therefore, clarity prevents confusion. In many cases, an interventional pain physician functions as a bridge, or sometimes a pit stop between primary care and spine surgery or orthopedic surgery. Primary care physicians often initiate conservative treatment, such as medications, physical therapy, imaging, basic management weight strategies, and so forth. When pain persists despite those measures, referral to an interventional pain specialist may occur before surgical consultation. There's something called the linear insurance approval model. When it comes to chronic pain management, such as managing low back pain or knee pain, for instance, insurance approval is typically structured as a linear progression. Most plans follow 4 steps: physical therapy, medication management, pain interventions or injections, and spine surgery or joint surgery. This is often called step therapy or graded escalation. The goal here is to begin conservatively and escalate only if necessary. So why does the linear progression model exist? The structured pathway, physical therapy, medication management, interventional procedures, and finally surgery, reflects system architecture, and it's not merely clinical preference. In other words, the stepwise linear pathway is not random. It was built to control system-level risk. From an insurance payer perspective, stepwise escalation supports cost containment and resource stewardship, ensuring high-cost interventions follow documented conservative management. Insurance carriers require conservative treatments before higher-cost procedures to ensure resources are used appropriately and sustainably. From a regulatory standpoint, it creates auditable checkpoints aligned with state prescribing laws, federal oversight, utilization review standards, and risk mitigation frameworks. It helps streamline regulatory oversight. In a sense, the linear progression model operationalizes accountability, balancing access, compliance, and financial sustainability. So while on paper, the linear progression of treatment protocols makes sense, but chronic pain itself is biologically nonlinear. For instance, a patient may complete physical therapy, medication trials, injections, and even surgery, and still experience persistent chronic pain. So that's when the linear model shows its limitations. Many patients eventually return to pain specialists for chronic pain management. Chronic pain, the mechanisms involving chronic pain, it may involve physical and central sensitization. It may also involve neuropathic components. It may involve mood and sleep disruption. So pain management is not just the step before surgery, it can also be a bridge or a decision point for coordination of chronic care management, including functional improvement for long-term chronic pain patients. The system is structured as a ladder, but chronic pain often behaves more like a cycle. Patients may also have persistent post-surgical pain. So for instance, persistent post-operative pain in a patient whose post-knee replacement refractory to either physical therapy and or is not a candidate for subsequent surgical revisions by orthopedic surgeons may benefit from not just chronic medication management, but also ablation procedures such as genicular nerve radiofrequency ablation, or even neuromodulation with peripheral nerve stimulation by an experienced pain physician. Such vital and crucial procedures may also be standard of care for morbidly obese patients or patients with multiple comorbidities who are not candidates for knee replacements. Pain referral preparation requires strategic navigation. When patients are awaiting referral to pain specialists, ask what documentation is required. Confirm insurance criteria. Bring your imaging reports. Clarify functional goals, because preparation improves efficiency. Now, pain specialists most of them think in terms of what are the pathophysiological mechanisms of chronic pain. How do we mitigate the risks while navigating through regulatory oversight? How can I provide functional improvement in terms of performing in terms of improving activities of daily living and or instrumental activities of daily living? Or how can I use multimodal strategies in chronic pain management? So there exists a language bridge when patients sometimes can feel dismissed. Now, I don't mean by specific linguistic ability, but rather an underlying relay of language between a patient and a pain physician. Improper relay of communication may lead to patients feeling minimized or labeled or disbelieved, because they might even think no one is listening to my pain and my pain is not taken seriously. Clinicians, sometimes due to the nature of their training backgrounds, may be overly risk conscious or more evidence bound or more or less regulation aware. Proper language bridges this gap. Alignment reduces adversarial tension. Friends, understand that chronic pain exists at the intersection of neuroscience, psychiatry, physical medicine and rehabilitation, anesthesiology, regulation, policy, and insurance companies. So it is inherently complex. Both sides operate within the same system. Chronic pain, the management of chronic pain is iterative, or in other words, something like a mathematical or computational process. It is risk managed, it is multimodal, and is function focused. And the goal here is not zero pain. The goal is improved function with some acceptable risk. So, focus on progress over cure is important, particularly relying on safety, stability, and functional improvement of patient. So friends, let's summarize what we have learned from this video. Chronic pain care is not simply a medical issue, it is a systems issue. It operates within regulatory oversight, workforce limitations, and subspecialty bottlenecks. The linear insurance model exists to control cost manage risk, and create a regulatory accountability. But chronic pain itself is biologically non-linear, and it's highly regulated subspecialty focused not only on procedures or medications, but on risk mitigation, multimodal strategies, and functional improvement. Primary care physicians provide continuity. Pain specialists, on the other hand, provide escalation and complexity management. Patients must navigate both. So when we understand the structure of the system, rather than personalizing its constraints, frustration decreases and collaboration improves. The goal here is, again, not zero pain. The goal here is to improve function and sustainable progress within a complex healthcare framework. Navigating the healthcare system requires understanding the structural models of pain management. So when patients, PCPs, and specialists understand the system, care for the patient improves. In my next video, we will talk about the fourth topic under living with chronic pain, which is patient expectations versus medical reality. This is Pain, Policy, and Practice. We will continue having these discussions. Bye.